Hi, and welcome to another author interview. I'm Brian Jacobson, one of the Associate Editors of Gastrointestinal Endoscopy, and I'm here with Dr. David Hewett, who's going to speak to us today about his paper, Miss Rate of Right-Sided Colon Examination During Colonoscope Defined by Retroflexion, an Observational Study. So, David, can you tell us a little bit about what you did in this study?
Yeah, sure, Brian. We conducted a prospective observational study of the value of retroflexion during colonoscopy. We were particularly aware of the issues with right colon examination in colonoscopy, so we wanted to evaluate a new intervention that would potentially add to the value in terms of yield of polyps in the right colon.
Because of people's recent fears that right-sided polyps might be missed more often.
That's right. So we wanted to systematically evaluate the safety and the yield of finding polyps in the right colon using retroflexion.
And so how did you go about doing this?
So we consecutively enrolled 1,000 patients in our study. We performed a usual colon examination in the right colon. We performed forward viewing first, and then we performed retroflexion in the right colon and systematically examined the right colon in retroflexion in 1,000 patients. And we showed that we were able to achieve successful retroflexion in about 94% of the patients, and we were able to find an additional yield of adenomas in 4% of patients overall.
And was there a particular type of colonoscope you were using?
We typically use standard adult colonoscopes in our practice. We use pediatric colonoscopes in specific circumstances. So we actually, in about 94% of the time, we were using adult colonoscopes, and our success rate in adult colonoscopes was about 94% as well. So we prefer and typically use standard colonoscopes and found that our success rates using them were quite high. In fact, our success rates in pediatric colonoscopes are a little bit lower. They were 88%, but that may reflect the type of patients that we were using them in.
Or possibly that they were a little more flexible? Maybe
Possibly,
they were looped,
absolutely.
or...
That's right, yes. In fact, that was our experience with the 60 or so patients in whom we could not retroflex. The perception from the endoscopist was that the reason for failure was looping of the instrument in the distal colon.
So for our readers who might be interested in trying this technique as well, you would do a good look going forward. Would you pull back, looking the normal way to the hepatic flexure, and then go back again to retroflex?
That's right. So our approach was to systematically examine the cecum, ascending colon, and hepatic flexure in forward view. We would then reinsert the colonoscope to the cecum, and at that point we'd attempt retroflexion. We were typically able to retroflex the colonoscope by keeping the colon relatively well insufflated, and sitting at about the ileocecal valve, we would then push the colonoscope forward, and with maximum up deflection and maximum right-left deflection, typically to the left, with left torque or counterclockwise torque, we were then able to achieve retroflexion in about 94% of the patients.
Okay. So that's important. So it's not intuitive, it's a leftward.
That was the way we typically
torque,
did it, although occasionally right torque was used, and it does tend to work as well. But our approach was typically to go maximally up and then maximally left, and then to left torque the instrument.
Were you concerned at all about possible perforation doing this?
No, but there's certainly a perception of the risk of perforation in the right colon, and that's commonly reported to us when we talk about this study, but it was not our experience, and in fact it's not our perception at all that perforation is a risk. So we were cautious, but we did not experience any problems with the 1,000 patients that we examined. We did have a small number of a small amount of mucosal trauma, but realistically it was minor and not of concern.
Okay. And then I think it's probably important for our viewers to recognize when you do this, the tip in retroflexion is actually not deep in the cecum, right?
That's correct.
More proximal.
Usually, in fact, we did not often achieve retroflexion in the cecum. Typically, the colonoscope would fall back into the distal ascending colon, and we would not be able to view the ileocecal valve on FOSS in the cecum. Dr. Rex has actually previously conducted another randomised trial of the value of adult versus pediatrics versus a special prototype instrument that was designed to demonstrate the success of retroflexion in the cecum, and so that was not the purpose of this study.
Very good. So has this changed your practice of colonoscopy now going forward?
Yeah, I now consider retroflexion in the right colon an important part of my practice. I think it's important to know, to acknowledge though, that this was not a controlled trial. We did not attempt to show that retroflexion was a required part of colonoscope examination. So we were able to show that we did find more polyps in 4% of the patients, more adenomas in 4% of the patients. But that may have been achieved by a second detailed forward inspection of the right colon. So, and in fact, the only other controlled trial of this particular technique was one that Dr. X did a number of years ago, where they did just that. They did a tandem study in the right colon and showed that the yield was actually equivalent from a second forward examination in the right colon.
I could see, though, that this might be a technique that is useful in some cases for performing polypectomy.
That was partly our perspective when we started the study, was that we certainly were aware, and we use retroflexion commonly for large polyps in the right colon to get better views, and often to inject, actually, so you can inject the polyp and bring it towards you in forward view. However, we were then conscious of the times that you often see polyps in the right colon in retroflexion that you weren't necessarily aware of how big they previously were. So, for example, the distal ascending colon up near the hepatic flexure is often invisible on forward view. And so we were wanting to more systematically evaluate the role of retroflexion in finding more polyps in that, for that reason. So it still may be important if we were to do more substantial studies of retroflexion, and with many thousands of patients, it may have a role in finding that occasional tumour in the distal ascending colon that's invisible on the forward view.
Well, thank you very much for sharing this study with us. We appreciate your time.
Thanks, Brian.